I'm going to move on to our next session. Our next two speakers, back to back, not at once, are both going to be talking more about the clinical experience, what's going on in healthcare right now. So it's a bit of a change from the rapid test. Rapid test can apply to every workplace. Now, these are the updates of what's going on, another year, another wave, and what is going on in our healthcare system. So first we have Dr. Kashif Pirzada, MD. He is an emergency physician practicing in Brampton and Toronto. He holds faculty appointments at McMaster University and the University of Toronto. Dr. Pirzada was a co-founder of the group Conquer COVID-19, which supplied PPE when supplies were scarce at the height of the pandemic. Very early on, outside of hospitals, in particular, healthcare workers were having a difficulty with getting PPE as PPE was earmarked for hospitals. So everybody else in healthcare was having challenges. That's what he was involved with. He's also co-chair of Masks for Canada, and has presented to many city councils across the country to try and get universal masking bylaws passed, which he was able to successfully help with. He's also co-chair of the Critical Drugs Coalition, which is seeking a permanent end to drug shortages in Canada. Clinically, in addition to his frontline emergency department work, he's led M&M rounds at his hospital and established a simulation education program, one of the only community hospital-based accredited simulation programs in this country. Dr. Pirzada, working in the emergency department and doing all these things I've talked about, was very busy and had other commitments at this time, but he so graciously recorded this update for us. He is going to talk about hospitals. His focus is GTA because that's where he's based, and he knows the emergency department, but he's going to update us from his standpoint what's happening right now. So we're very appreciative that he did this.
Hi there, my name is Dr. Kashif Pirzada. I'm an emergency physician in Toronto, and I'm going to give you a quick update on the clinical front lines and an introduction to our group, Masks for Canada. By way of background, I'm an emergency physician working in a number of hospitals in the GTA, also working as a coroner. My introduction to the pandemic was through text messaging from a friend, sending a message about a warning about a viral pneumonia in China. A lot of frantic preparations later, and the authorities here, as you've discovered, were pretty lackadaisical about it at the start. This is not my first coronavirus. I was a medical student during the SARS epidemic in 2003 at the University of Toronto. I was quarantined after an exposure at St. Michael's Hospital. And one of the reasons I've been very active is because of remembering what that experience was like. I saw probably Canada's third POI case, a person under investigation, almost exactly a year ago, 2 years ago. And yeah, it was quite an eye-opening experience. It triggered a whole bunch of drill preparations at Sunnybrook and other hospitals, assuming that the response would be escalated at higher levels and that there would be greater preparations. But we discovered by March of that year that that wasn't the case. I also presented a brief to Parliament recently about drug shortages, critical drug shortages, which is still a continuing problem even today. Um, One of the groups I helped co-found was called Masks for Canada, and the situation in the spring of 2020 was that there was mask mandates were considered ridiculous at that time. No one was willing to entertain it, but it was an option that was politically popular. But the willingness by public health officials on the front lines was very low. This is a response, an email response actually from a public health official at that time, saying that enforcement would be impossible. There's equity issues. The population might reject it. Our response was to organize a group, Masks for Canada. We did a public relations campaign, a campaign to lobby city councils across the country to gradually adopt mask mandates. We convinced one large GTA suburb to do so, and then the rest of the cities fell like dominoes. And thankfully, I think it's really contributed to decreased case numbers in Canada compared to our immediate neighbors. This was a letter um, uh, regarding airborne spread of COVID-19, an issue that still is not being taken seriously by many public health officials. This was co-signed by Masks for Canada over a year ago. And yet, despite all that we've learned, we keep on our respective Titanics, always on the verge of hitting icebergs with this thing. And I think it is something that you folks are familiar with, is the struggles you have with authorities that refuse to look at updates in the science to really understand that things have changed. This was reflective of the situation at my hospital early on in the pandemic. I went to a meeting once, and the infectious disease head said, "Take off that mask. You know, that's not necessary. It's a droplet spread illness." It was only until this publication by Dr. Atul Gawande that really a sea change happened in Toronto area hospitals where mask mandates were imposed. Um, and really, I think in Toronto, you've had more of a willingness to adopt precautionary measures because of the SARS experience. Many physicians and nurses in leadership positions in Toronto remember that time and have been quick to adopt precautions as conditions have changed. Precautionary principle, as we've discussed, it's unevenly applied. We have a fairly cautious set of health leaders in Toronto, but that might not be the case and appears not to be the case across the country. And I always find, this is a way that I find opposition breaks down. It's nothing changes, and there's sort of a helplessness, a fragility, a false consensus, dogma, appeals to evidence that can never really be collected. And in the end, nothing changes. And this appears to be the case, across the country. And I often, look at it this way, like a fight between two groups that really shouldn't be happening. There should be more of a cooperative venture between every sector of the science establishment to get this under control. Now, the current situation in Toronto is that we're seeing that a steady rate of admissions in hospitals here. These are mostly elderly, frail elderly who are fully vaccinated, immunocompromised, unvaccinated, of course, and some children, which are starting to come in larger numbers. Bed pressures have been quite severe, especially in the last week. They seem to be easing slightly. We'll see when the numbers come in on hospitalizations. But a week ago, hospitals were drafting physicians to work in the emergency departments to help ease pressures. So that is happening less and less. Another variant that's more severe or waning immunity could tip us in either direction at this point. Regarding masks and ventilation, ERs in the GTA have largely switched over to N95s in clinical areas. This occurred in late fall, early winter, when the science table head endorsed that it was airborne, and then directives went out from Ontario Public Health shortly afterwards. Most are 3M products, especially the new Softwell Aura masks, which are very popular and quite comfortable just speaking to colleagues. Many hospitals in the GTA have ventilation upgrades since SARS. Newer buildings, especially when I work at Humber River Hospital, has at least 6 to 10 air changes an hour in clinical areas. Situation is less clear outside of the emergency rooms in older areas and ward settings and in the rest of Ontario and Canada. And it appears, surveying colleagues in a Facebook COVID Facebook group that we share, it appears that the adoption of N95s in clinical areas and ventilation upgrades is not happening in most provinces, especially in the West and in Quebec. Rapid tests, it's disappointing, a technology that's been, known since Michael Mina's editorial in the New York Times 18 months ago, that their value was only recognized by our government just in the last month. And unseemly scramble for tests, humiliating lines stretching around the block became familiar. But we could have stockpiled these things. We could have had millions upon millions of these tests had we done our homework. If our leaders had done their homework, they are not being used regularly in clinical settings in the ER. They are, I believe, mostly being used in long-term care settings. PCR swabs are the main testing modality for the emergency room and inpatients right now. And again, I wanted to thank the group for your continued advocacy and for airborne precautions. Thank you for the opportunity to present to your group today.
Okay, so that was our brief update from the emergency rooms, emergency departments. We had hoped to get someone from community medicine as well as ICU here, but everyone that we reached out to was understandably far too busy. Although we are hearing numbers that perhaps we are getting near the end of the wave, those working in healthcare still are busy. So I'm very grateful that Dr. Frazada made the time to record that, and also very grateful that we have Ashley Fox next. Before I introduce Ashley Fox, though, Dr. Prezada talked briefly, talked about the N95 use in the hospitals in the GTA. That is not the experience outside of the GTA. It's certainly not the experience where I am in the Kingston area, or at least the last time I was there, which was a few weeks ago now, 3 weeks ago. But so if anyone wants, just before we go on to Ashley Fox, if anyone wants to share if they are in a healthcare setting, if they have mandatory or any setting, just let us know in the chat where you are, what setting you're in, and if you use mandatory N95s or if you have the option of N95s, that's also good to know. Just out of curiosity, as a very informal scan. So please feel free to let us know in the chat. So